sir, you can start the session. Hello. Hello.
Can you hear me?
Yes, sir, you can start the session.
Okay, right. Okay, we'll start now. I will say, yeah, I will share my, I will share my screen now. Can you see my slide?
Yes, sir.
Yeah, right. It's heavy rain here. That is why probably you may not be hear me very well. Anyway, this is a story of a 43-year-old man. He presented with numbness of both feet below ankle for the last 4 years. Numbness of both index finger for the last 2 years. Burning pain of whole body, mainly over the feet for the last 2 years. Numb feeling, he said, specifically said not paresthesia, some feeling, some tight feeling for the middle two fingers for the last 2 months. And thickening of the skin over the left pinna for the last 6 months. He said numbness of both feet 4 years. Numbness of both index finger for the last 2 years. Burning pain of the whole body, mainly over the feet for the last 2 years. Numb feeling of middle two fingers for the last 2 months. And thickening of the skin over the left pinna for the last 6 months. This is a video of the patient. He got a glossy, see the fingers appear more glossy and little more erythematous the tip of the fingers. Tone was normal. deltoid normal, biceps normal,
നല്ല മടക്കി പിടിക്കുക. നൂത്തി വീങ്ങി
triceps normal, wrist extensions, finger extensions are all normal.
പൊക്കുങ്ക, ഇതും പൊക്കുങ്ക, പെരലി മടക്കുങ്ക, മടക്കി പിടിക്കുക.
Long finger flexors were normal.
അകന്നിരിക്കണം.
The finger abductors, palmar finger abductors, I'll come to that later. The opponent's policies is normal. But if on the ADM on the right side is weak, abducted digital is appeared weak, left side appears normal, good power. That is a finger is a required numb feeling. Other intuition appeared normal. Then I check the common sign that is negative. Then I check the palmar intuition that is normal on the other two fingers, but that finger it is weak. The fourth palmar intuition was weak. There it has got a good power on the left side, but weak on the right side. No finger nose in coordination. Lower limb tone was normal. The power was normal. EHL, twist flexes, plantar flexes are normal. Come to the reflexes, were normally elicited in both upper and lower limb. Ejects were normally elicited, slightly brisk on the left side. Angle jack normal. Plantar was flexor, but rather independent, not upgoing or outgoing. The sensation, he was missing that sensation on the middle finger on the right side. Probably you're not able to hear the sound. Is counting except the middle finger is not counting. The distal part also he was not able to feel the sensation. But the pain sensation was lost in the middle part of the leg.
എന്റെ കുത്തിന് വ്യത്യാസം എടുക്കണ്ട ചൊല്ലെങ്കിലോട്ട് വേണ്ട.
Is not able to do dorsal aspect of the middle and the index. Thumb is
normal. ഒരേ മാതിരി தான்.
There he is feeling bad pain and he will show
கம்மியா இருக்கா? நீ வித்தியாசம் சொல்லுங்க.
That's ring finger it is normal.
நார்மலா இருக்கு.
Sorry, it is decreased. Little finger normal. They're all equally same. On the right side, right side decrease on the index and the middle finger, the dorsal aspect. That's normal. Ring finger is normal. Only the index middle finger is not able to feel the pain. But on the palmar surface, all he is able to feel normally.
നോർമൽ தான்.
Is a normal.
നോർമൽ. ഇത് ഇങ്ങെല്ലാം ഉണ്ട് ഒരേ மாதிரி தான். വ്യത്യാസം கிடையாது. இல்ல வைப்ரேஷன் தெரியுதா கிரர்ன?
Vibration is able to feel in all fingers.
இப்ப தெரியுதா?
Is able to feel.
தெரியுது. இப்ப தெரியுது.
Is able to feel all. But the toes is not able to feel the vibration.
தெரியுதுல? நடக்கு.
GP sensation is normal in the upper limb. He said correctly. But all the toes he made mistakes.
தெரியல.
He said no. He couldn't say where it was. So look at the gait of the patient. It is got normal. He could stand on toes and heel. That is able to do that. Rhombus is negative. So positive finding, failures were normal. Skin of the both palms appeared more glossy and erythematous. Tone normal in both upper and lower limbs. However, mild weakness of right abductor digitally minimi and right both palmar interosseous muscles on the right side. Rest of the muscles were normal. And rest of the muscles supplied with ulna as well as other muscles in the upper limbs and lower limbs are all normal, except these two muscles were weak on the right side. That is the area we is complaining of some numbness on the right index finger. DTR normal in both upper and lower limbs. Band are indefinite. Sensory system. Touch, impaired touch over the dorsal aspect of the middle fingers of both hands. Rest of the areas of upper limbs, normal touch sensation. Pain, impaired pain over the dorsal aspect of the middle three fingers of the right hand, up to the dorsal aspect of the wrist, and over the middle and ring fingers in the dorsal aspect of the left hand. However, on the palmar surface, all the sensations are normal. Only at the dorsal surface, the middle three fingers on the right side and middle two fingers on the left side, it is decreased on the left side, or decreased. Coming to the other sensations, vibration joint is normal in the upper limb, but both are impaired over the field bilateral. Rhombosis is negative, gait normal. There is some visceral skin lesion of the left pinna that I will show now. That appear little thickened and irregular. The right side is okay. So what is a likely diagnosis in this patient? Site of lesion diagnosis.
Sir, LMN syndrome probably reflex.
Okay. Not only element, sensory is also sensory is more affected than the motor.
Multiple mononeuropathy.
Correct, multiple mononeuropathy. So what do you think could be the etiology in this patient?
Sir, any history of arsenic exposure in the patient?
No history of arsenic exposure.
Any thickening of nerves, sir?
No, in fact, I'll come to that. No thickening of supratemporal and auricular dorsal. Some suspicious thickening of the ulnar.
Sir, it can be an inflammatory or a vasculitic process. However, there is no pain.
Pain was here telling all throughout the body.
Okay, sir. Can be a
Etiology.
vasculitis or
Okay.
a metabolic.
Vasculitis, yeah, right.
Hansen's Silpromatic.
Okay.
With lepra reaction of Hansen's can be a cause.
Okay, very good. So the point is that the diagnosis of Hansen is correct. Why? That's the point. Why? What is not
Infiltration of
Ulnar
the
nerve
earlobe,
involved.
sir.
No, there's not definite thickening of the ulnar.
So even when the nerve is involved, the deep tendon reflexes were preserved, sir. That is 1 point for Hansen's.
Okay, that's
Because-
agreed. That's agreed. That's
Ear-
point agreed. But the point more importantly, what?
Ear involvement, earlobe involvement.
Earlobe involvement is one. Second thing, but there is no sensory. It's not complaining numbers of this ear. But the more important, you look at the dorsum of the hand. It is lost only on the dorsal aspect of the three fingers of both hands, not on the
Root
palmar
involvement,
surface.
sir.
That means that the affection is in the cutaneous nerves.
Middle cutaneous.
That is in the cutaneous nerve of the radial and median and ulnar, not affecting the nerve per se. That is the point favoring a Hansen disease. See, if you are due to ulnar or median, we are expecting loss in the palmar aspect also. But it's not affecting the palmar aspect at all. Only the dorsal aspect is also. That too, it spared the thumb and spared the ridge finger. Okay. If it had been median, it would have affected the thumb, or radial effect would have affected the thumb, but it's not there. Only in the distal part of that kind of means only the digital nerves are affected. That's a more important point favoring a Hansen disease. So what else you want to do? There is no hyperpink patches, no thickening of late auricular nerve, common parotid nerve, suspicious thickening of both ulnar nerves.
Split skin
So, okay. See, conduction was done. Conduction showed sensory motor peripheral affecting both the lower limbs. Not
But-
only sensory motor is affected,
Biopsy.
biopsy, okay. So sensory motor neuropathy and right sensory ulnar. See, when in the upper limb, only the sensory potential is not in the ulnar, just the ulnar, but not the motor part is normal. See, the ulnar part, motor is normal, but sensory alone is affected. That also it picks up the cutaneous nerves. Superficial nerves are affected. So start examining the sensation of the pinna.
இந்த குத்துது
It is
இந்த
decreased.
குத்து வித்தியாசமா இருக்கா மரப்பா இருக்கு
Is no sensation of the pinna.
கிடையாது இல்ல இது நல்லா இருக்கு இது நல்லா இருக்கு இதும் sorry இதும் வித்தியாசமா இருக்கா
He said there also it is decreased on the right pinna is also decreased, even though you had no skin lesions.
இது வித்தியாசமா இருக்கு
When you start examining the trunk for any patches, there is no patch on the trunk. But there was an area where vesicular some lesions in the chest, you can see the anterior part of the chest.
எவ்வளவு நல்லா இருக்குது
Then I started, I asked him how long it has been there. He said it's been for 1 year.
ஒரு வருஷம் மட்டும்
Then I started examining sensation.
வித்தியாசமா இருக்கா
It was decreased over that area.
கம்மியா இருக்கா
That area is decreased.
ஜாஸ்தியான சொல்லணும்
Until when it is more,
இங்க ஜாஸ்தி
there he is able to feel the sensation.
சொல்லணும் இங்க ஜாஸ்தி இங்க எல்லாம் ஒரே மாதிரி தானே
In the back, there is no sensory one. There is no area of sensory loss. So ultrasound abdomen, thickening of both ulnar nerves and dermatologic consultation is suggested done a skin biopsy. That's being the result is being aware. But I am sure pretty sure it is an Hansen disease. Now look at the picture. This kind of the vesicular-like lesions can be seen in Hansen disease. This is the lips, but in our patient it was we see this kind of vesicular-like lesions. And this is extreme form of thickening of the skin of the pinna and Hansen disease. But look at our patient, it's also about thickening of the skin and something similar to that and is here on the our patient. This is extreme form from the literature. This is our patient. So the point here, even if you do not get nerve thickening or patch, whenever the sensory loss in the distribution of cutaneous are affected, deep nerves are not affected, motor nerves are not affected, always keep this possibility in mind. Because the lepra bacilli grows in the cooler areas of the body part. Always the dorsal surface is cooler than the palmar aspect because there is a thick, the palmar surface, there is a thick cuticle of the skin. The skin is quite tight, whereas the superficial part, it is very loose. So it's more colder on the dorsal aspect than the palmar aspect. So in Hansen disease, they do not put the sensory loss in the palm, only at the dorsal aspect. The palm is more often due to a tubercular cancer, where it affects the nerve per se. Nerve per se is that. But per se, lepra bacilli usually prefers to be in the cooler areas of the body. That is where the pinna, forehead, these areas are affected. Okay, shall we go to the next case?
Sir, one question, sir.
Yeah, please.
Sir, in this patient, the ulnar innervated muscles were weak on one side, but
Yeah,
sir,
correct.
the potentials were normal, the CMAPs were normal.
Correct.
So can it be because of a proximal conduction block pattern or something? Generally, Hansen's is an axonal pathology.
Right. What you said is perfectly right. It is not due to the conduction block, but if you do very carefully, the muscle affected is only the fourth palmar interossei and the abductor digiti minimi. The other muscles are all normal in the hypothalamus. The potential can be picked up from any of the muscles from separate by the arm. See, the affection is so selective that probably that muscles, that branch is affected from the ulnar, not the entire ulnar nerve is affected. That is why the CMAP is normal. And the three muscles, only one is affected. So all the interossei, adductor pollicis formants are all negative. Only the fourth palmar, that's the first thing to go in ulnar nerve. That's called the Wattenberg sign, where the patient puts on the hand, little finger will jut out.
Is it similar to the fascicular vulnerability principle as we see in amyotrophy or other?
Yeah, maybe yes, but as you said, In the case of Hansen bacillus, has got a peculiarity. It affects only the branches of the nails may be affected. It may be affected the hand itself, but only one branch may be affected. But your point is well taken. The vesicular vulnerability can be explained because in proximal ulnar nerve lesion, the early phase, the only or the earliest muscle affected may be the fourth palmar inclusion. That way, your explanation also can be true. But
The
the disease
vibration senses were normal in this patient from the upper limb.
right. That's also the very important point to diagnose Hansen disease because the Hansen affects the small fibers. The large fibers are largely spared. The vibration and JP sensations are carried by large fibers. That is why it's essentially a small fiber neuropathy. That is when the pain and temperature is lost first, trophic changes occurs first. That is where reflexes tend to be preserved because reflexes are carried by large fibers. The joint presence, even the ulnar, where the sensory loss is there, JPA sensation and vibration is preserved. But it does not mean that large fibers cannot be affected. It can get affected. There are sufficient literature to say that even dorsal root ganglion can be involved, and the spinal cord can also be involved. All this well known in Hansen disease. But the classical garden variety is it's a small fiber neuropathy, sparing the large fiber. That is where the classical teaching is that you get pain loss, but the reflexes are brisk or well preserved because the large fibers are preserved.
Thank you, sir.
Yeah, that's a tendon junctions also is large fiber because it's deep-seated nerves. They're all preserved.
Sir, but joint position is impaired, no, sir? And
Yeah, in the
vibration
lower,
is also impaired in the lower.
right, yeah, right. In the lower limb, the upper
That
limb,
is
they are
also
not
large fiber only.
exactly what you said is correct. So that's what the lower limb it is classically sensory motor neuron. Motor fibers are also affected, that also affected. Agreed. They cannot get in, they can also get involved. But the lesser extent compared to that of sensory.
Okay, sir.
Okay. Then just 1 minute. Okay, shall I go to the next case?
Any reason
sir.
for the tendon
Yeah,
reflex?
please. Any?
Reason for the tendon reflexes to become brisk?
Well preserved, that's all I can say. Because the large fibers are all preserved. Moreover, you see that the tendon reflexes are carried by the one fiber, they're all deep-seated, not only that, at all the skin surface. They are going from the muscle spindles, going to the deeper structures and going through the nerve and coming back to the muscle itself. It does not come up to the area of the skin surface at all. If at all the large fibers are affected, touch alone will be affected from the skin. So the joint presence sensor all and the joint sense and vibration as well as the deep reflex are all carried by fibers situated deeply in the limbs. They are not on the surface. It will become little warmer areas there.
Sir, abductor digita minima is affected in one hand, no, sir? But
Yeah,
ulnar nerve, motor ulnar, same map is normal.
That's exactly the other doctor was also asking the same question. It can be explained two ways. One, you can say vesicular vulnerability, but the point again is that is the first muscle affected the fourth palmar. The ADM is not the first one to be affected, but the other explanation is that Hansen being Hansen disease, it may pick up only branches of the nerve. For example, to give an example, you take the facial nerve involvement. In Hansen disease, classically affects only the upper part of the branches of the patient. Totally spares the lower part of the face. So that is why you get only that too in the middle part of the frontal branch may be affected. So what do you call it? The witch's face. The lateral part will go up, the middle part will not contract. The eyebrow will go like that. So that is a peculiarity of Hansen. Only affect picks up branches of the facial nerve. And orbicularis oculis may be affected, oris may be affected later, but buccinate is never affected. So that is when they smile, you get a so-called buccinator smile, because there will be puckering of the lips will be there because of the weakness of the buccinate. Buccinate is separated by deep nerve, but other facial muscles are separated by superficial nerves. So it characteristically affects only branches of the nerves in Hansen disease.
Okay, sir. Thank you, sir. Vaccinator is supplied by trigeminal nerves.
Pardon? Which one?
Vaccinator is supplied by trigeminal nerve, sir.
No, buccinate is separated by seventh nerve. Seventh nerve. Buccinate is also a facial muscle, but it is deeply situated. That is why it is not affected by Hansen disease. All of the superficial muscles, the way they are in the polar area, exposed area, they get affected in Hansen disease. Okay. Shall we go to the another case?
Yes, sir. Yes.
Okay.
Yes, sir.
Just 1 minute. Okay, sorry, it's a heavy rain outside. There's to go out and to clear something. Okay, shall we? The next case is a story of a 53-year-old man. Old case of type 2 diabetes for the last 4 years. This is also a short case, but interesting case. History of numbness and burning pain of both feet up to the knee for the last 3 years. For the last 3 months, he noticed that his left foot will get deviated inside while walking, which made him fall on 2 occasions. No complaints pertaining to the upper limb. So I'll go back to the history once again. Non-diabetic for the last 4 years. Numbness and burning pain of both feet up to the knee for the last 3 years. For the last 3 months, he noticed that his left foot will get deviated inside while walking, which made him fall on 2 occasions. No complaints pertaining to the upper limb. Let us see the findings now. The normal tone of the lower limb.
ഈ കാല് പൊക്കി പിടിച്ചോ.
Deflection was normal.
ഇത് പൊക്കിക്കേ. കിട്ടോ പിടിക്ക് സ്ട്രെയിറ്റ് ആയിട്ട് പിടിച്ച്.
Knee extension normal.
ഇത് സ്ട്രെയിറ്റ് ആയിട്ട് പിടിച്ച്. കിട്ടേ.
The was normal to the right side. But see, his tibialis center is normal. It's conducted normally. The inversion of the dorsal position is perfectly normal. It was normal on right side as well as left side. Normally, but eversion was normal on the right side. But even he cannot keep it everted at all. It goes inside. Keeping it everted, but automatically it goes in inversion. See, it goes in inversion. He cannot keep it everted at all. Check. The inversion was normal on both sides.
Very good.
Again, check the inversion on left side. Right, left side he cannot evert at all. Even the plantar flexion eversion was 0. Plantar flexion normal. Flexor is long as also normal.
ഇത് ഇറുക്കി പിടിച്ചേ.
But the adductor hallucis is weak bilaterally. He's a diabetic. Hip abduction normal.
മതി വിട്ടോ.
Hip extension
ഇത്
normal.
തള്ളിക്ക്. മതി വിട്ടോ.
Come to the reflexes. Both knee and ankle jacks, left knee jack is elicited, right knee jack is absent. That's right knee jack
കൈ
absent.
മുറുക്കി പിടിച്ചേ. കൈ പിടി, രണ്ട് കൈ മുറുക്കി പിടി, കൈ മുറുക്കി പിടി.
Left is elicited on the left side. Both ankle jack were absent.
കൈ മുറുക്കി പിടിക്കണേ.
Plantar was indefinite. Sensory loss, he was complaining only on the look. That area is complaining sensory loss.
ഈ
But that both sides is like that.
ഒട്ടം പറയണം.
He will tell you it is not
അതെ,
there.
അത്രേ എനിക്ക് വേണ്ടു.
It's not decrease the lateral side of the
നോർമലായി പറയണം.
calf. There is able to feel. Same on the other side.
അതേപോലെ അറിയാമല്ലോ.
Not on other areas. Soul it is normal.
ഇപ്പൊ ഉണ്ടോ?
Not able to feel the vibration bilaterally.
ഇല്ല. ഇല്ല. ഇപ്പോഴോ?
It's also decreased on the thumb and the big
Pere.
toe.
ഇപ്പോഴേ?
Made mistakes.
ആ.
A made mistakes.
ആ. ശരി.
SLR was negative.
അത് കൊടുക്കാതെ. ശരി.
He could stand on toes, but the foot goes into inversion. See that the left side goes into inversion. Plantar pressure was good.
ഇങ്ങനെ ഇങ്ങോട്ട് വരാൻ പറ്റും.
On standing on heel, the left foot goes in inversion. So the findings are confined to the lower limbs. Tone normal. Motor, right lower limb, power normal in all the muscles. Left lower limb, hip muscles normal. Knee extensor plexus normal. Angle tibialis anterior, extensor hallucis longus, finger extensors were normal. Weakness of evertus in the left ankle. Plantar flexion, flexor hallucis longus normal. Adductor hallucis weak bilateral. DTR knee jack absent on the right side, present normally on the left side. Angles both absent. Plantar indefinite. Sensation impaired over the dorsum of the both feet. Normal over the lateral aspect of both the legs and over the soles. Impaired vibration JPS over both dorsals. SLR negative. This is the area of the dorsal aspect of sensory loss in the feet. So, where is the localization and like detail? You want a clarification of the findings? I can tell you once again.
Sir, was he a well-controlled diabetic or a poorly controlled diabetic?
Said it's already literally good under good control.
Okay.
Sir, only the evertus were weak, sir. Only the evertus and the
Only the evertus were weak.
adductor hallucis, sir.
That is weak bilaterally. That's because maybe part of the pyramid. So that is bilaterally may make me think they may be unrelated to the present problem. Maybe he has already got a peripheral neuropathy, absent and conditional impairment of JPS and vibration both sides. So that may be part of the peripheral neuropathy.
So the sensory loss pattern, whether the first interdigital cleft was paired, sir, on.
No, it was there. In fact, it's a distal loss. Bilaterally, it is not only in the left side. The area affected will be like this bilaterally. This is where it's telling. Something like a stalking pattern, but it's only confined in the dorsal aspect, not on the palmar aspect. Sometimes it can occur.
So the total duration of history is 3 months.
3 months. 3 months.
So even though he is a diabetic, we have to consider demyelinating etiologies like painful neuropathy like DADS in this patient.
But only one left leg is affected, no? No other part is
But
affected.
sensory involvement is not wider.
Right, that is a diabetic, no? That is never bothered about that part at all.
So the burning pain that he was having.
Yeah, that is any diabetic will have no sensory neuropathy, abiding, but it's very quite common. And he
Yes.
did not have any sensory loss of the soul also. So that I don't think yeah.
Bilateral, either bilateral superficial peroneal alone can be affected, sir, but the sensory loss is over the L5S1 distribution, sir.
Yeah, that can be a fair distribution.
Yes, sir. Only the inverters are weak, so we can restrict the weakness only to the inverters of feet in the sense we can attribute the lesion to superficial peroneal neuropathy, bilateral superficial peroneal neuropathy itself, sir.
Perfectly right. That's the thing. So see how can you got a zero power of the aortas. So all of them are supplied by the deep peroneal is normal. Which are the muscles of deep peroneal, tibialis anterior, extensor hallucis long. They're all perfectly normal. So that means that it's only the aortus are weak. That is supplied the superficial peroneal nerve. So definitely you could evidence the supraperoneal neuropathy on the left side, and that is his complaint also. But on the right side, the sensory loss is there bilaterally. So it could be part of a early neuropathy also, we do not know. But whatever is the present problem is, he's come with inversion of the foot while walking. That has to be sorted out. So we have to think of supraperoneal neuropathy or some conperoneal compression with predominant affection of the supraperoneal. Okay. You agree with the diagnosis?
Yes, sir. Yes.
Okay. Now let us see. Is it conperoneal palsy, left S1 radiculopathy, or cortical foot? This naturally you should keep in mind, because what is again supraperoneal nerve palsy is that the sensory loss is not in the distribution of supraperoneal, because it is not affected the rest of the dorsum or the lower lateral part of the leg. That idea appears paired. Okay.
Yes.
So that's one odd point against supraperoneal nerve palsy. Of course, radiculopathy cannot be totally ruled out, but the odd point is the other muscles supplied by the alpha root is not affected. So it's very much against the radiculopathy. Conperoneal nerve, again, point again is the tibialis anterior, knees are all spared. So most likely either superficial peroneal nerve palsy or a cortical foot drop, a possible, rare possibility. So what investigation do we need here?
NCS, sir.
Okay, NCS. Okay, this is NCS. See the right and left peroneal, EDB, normal amplitude. Tibial side pick up normal. In the tibial nerve, both pick up from the abductor hallucis brevis is normal. But mild velocity decrease, I think you can ignore that thing. And sensory, absent potential from both superficial peroneal and both sural. And FA is normal. So, what do you think now?
Hansen's.
Hansen disease, how can produce only the superficial peroneal that nerve alone get affected?
Yes, sir.
Pardon? Only motor part is affected, sensory is not affected.
Sensory also is there, no, sir. Sural.
Here it's bilaterally affected, no? See here, both superficial peroneal and sural are affected, means it's got it's a diabetic peripheral neuropathy, sensory peripheral neuropathy.
So though
If it's
both the signs are absent, can be attributed to diabetes. His right knee jerk is absent, sir, without any.
right, that's of course. Here the right knee jerk seems to be absent, which I can't also explain. But there must be some other lesion, but that is not his complaint. Whether there's some other lesion there, okay, we have to investigate for that thing. But he has come with a specific purpose problem. So no, suppose somebody has come with weakness of the left lower limb, if something else is fine with the other thing, that not be related. Okay, that needs investigation later on. But his primary problem is his left foot is going inverted. He has no complaint regarding his right knee jerk loss. If you can correlate that abnormality with the present one, well and good. If you cannot correlate, think it aside. Can you correlate with the right knee jerk absence with the left aortus weakness? You cannot correlate. So keep that knee jerk loss separate. See, neurology, many times you come across some findings here and there, which is not tallying with your localization of the complaint. You keep it aside. If you try to correlate if it's possible, otherwise keep it aside.
So it can be explained with the two types of diabetic neuropathy. One is distal symmetrical and another is neuropathy multiplex. Both can be caused by diabetes.
One is multiplex means what? Knee jerk, you mean? Knee jerk only?
Femoral
That may be early peripheral neuropathy, agreed. Multiple. But this person, okay, that is agreed. But how often do you find that only superficial peroneal involvement in a mononeuropathy of diabetes? Usually it is a conperoneal which is getting involved, no?
Sir, can it be like any cortical dystonia? Like
No, it's not dystonia because it's not a persistent abnormal positioning at all. It's only weak. You cannot keep even in the inverted. It goes inside. It's not overaction of the muscle, no. No doubt inverters are zero. That is weak. Okay, now what will you like to do?
Sir,
Imaging has to be done. Very good. So what I did is I did an EMG study. I wanted to know what is happening to the... See, the EDB is supplied by the deep peroneal. Okay, that is why the potential has become normal. And from the left, no spontaneous activity in the left EDB, except occasional resignation. That may be part of his peripheral neuropathy part. Then they started putting pressure on that thing.
Maximum
good interference from the left EDB. That means EDB is paired. He had got mild innervation, agreed. But he said that means you expected innervation of the other muscles may be there. He's a diabetic also. So then I wanted to pick up from the left peroneus longus, the muscle which affected, clinically affected. That potential is coming. There is no potential. He's not able to invert at all. No potential is coming up from the left peroneal. For the right peroneal, I did the same thing to find out whether my technique is correct or wrong. There again, I can find even the unaffected limb, occasional fibrillations are there. But a fibrillation coming up. But he has got a almost normal EMG.
Maximum. Correct.
His effort was little less, but almost normal on the right side as well. Normal power. Now what will you do? EMG did not pick up any potential in the left superficial peroneal. From the EDB, I could pick up normally. So also from the right superficial peroneal muscle. It's a right peroneus longus muscle.
MRI of LS spine.
LS spine you want? Do you think a radiculopathy is possible in this patient? How can radiculopathy, where it only affect the muscle severus of zero power, sparing the EHL? The first muscle to be affected in L5 radiculopathy is EHL. Unlikely to be radiculopathy. Anything else you want to do?
So because of selective muscle involvement, we can think of dystrophy, sir.
Only one limb is affected. Only one limb, one group muscle alone is affected. When you get that pattern, think of a mononeuron, that nerve is get involved by some means. Either in the form of a mononeuropathy, inflammatory, or a vasculitis, Pressure, commonest you will think of a pressure palsy.
MRI
nerve
around joint.
MRI of?
Knee, sir, knee.
Right, correct. MRI of the knee. So I did one more thing. I put a pickup electrode on the peroneus. Because I wanted to be sure whether it's really the absence button on the peroneus is it's not a technical fault or not. So I put up the pickup electrode on the left peroneus and stimulation of the C-pin at the fibula. I tried to stimulate. I'm stimulating the fibula head, and pickup electrode is in the superficial peroneal. Look at what is happening to the muscle.
It's inverted.
It goes into inversion and no inversion at all. That means his peroneus longus brevis is not contracting or not producing any movement. But nerve is stimulated. Why nerve is stimulated? Because it's going to the dorsiflex. Now let us see the right thing I did. I want to know whether it's same thing occurring on the right side. It goes into the dorsiflex on the right side. I'll show once again. Electrode there. Normal contraction from the EMG from that thing. Then I started stimulating. See how the foot goes. Dorsiflex and inversion. See, that's the thing. Unlike the previous one, which goes into inversion. Okay, that's it. So that now where is the solution? Now we know that the nerve is stimulated, but it's not reaching the peroneus longus and brevis muscle.
Sir, after the common peroneal divides into deep peroneal and superficial peroneal. That is the cell.
Very correct. So we have to think something there, no? That is a correct logic. You want to think logically. So there must be some problem in the after dividing the thing, the nerve has affected something. The superficial component peroneal nerve is affected. That means it is distal to the conperoneal nerve. After it has given out the branch to the deep peroneal, there is some problem there. So what will you like to do? MRI of that area. Yeah. So it's got a pressure palsy, but it's, the superperoneal become deep at that level. I'll come to that later on. So MRI was done. So this first MRI, you can see that the hyperintensity is in the lateral compartment, only very minimally in the anterior compartment. I'll show the next picture. See, this is the lateral compartment. The anterior compartment is that one. There's not much of hyperintensity. So the bulk of affection is mainly in the lateral compartment. Now let us see, as we discussed before, we want to see the nerve. We want to see the conperoneal nerve and we want to see the divisions, deeper and superficial. So we started examining for the nerve pattern. See, I'll show that little later. Okay, there is the two divisions of the conperoneal nerve there. That is the deeper on. I'll show the screenshot. See, this is the trunk of the conperoneal nerve. Okay, what is shown here. Okay. Now below that, after dividing into two, you can see the division. This is the trunk. Now divided into two, you can see the two dots there. One is a deep peroneal, one is a superficial peroneal. Now after that, it's again a little more separated out. Then it goes into, this is the deep one, that is a superficial one. Okay. Again, it's very unusual set for a pressure pulse. See, the muscle is it is underneath the muscle only. It's very difficult. On the other hand, conperoneal will be affected because it is when curves around the head of the fibula, that is the area it's liable to get pressure pulse. So this is the nerve there. Right? That's again deep branch. That is superficial branch. Then the radiologist picked up some very interesting finding. He picked a finding. We cannot, I couldn't make it out. He could explain to me, and I'll show the picture later on. He said thickened peroneus longus tendon with intra-substance hyperintensity, so a small amount of fluid, so tendinosis. Then flattened with intra-substance hyperintensity of peroneus brevis retromalleolar inframalleolar region. Tendinosis with underlying early split tear Then visualized portion, the distal peroneus group of muscle shows intrasurface edema. So that is the observation. He said the peroneus brevis tendon is got ruptured, plus some inflammatory change in the peroneus longus. This is what he has shown below the malleolus. That is what? That is malleolus. Now, if you sentence about this peroneal tendon rupture, chronic tears are more common. One may remember the onset, rolling or hurting your ankle. These injuries happen slowly over time due to gradual stress and pressure on your tendon. Pain around your ankle may come and go, and you might not know what is causing it. Symptoms of peroneal tendon include pain along the outside of your ankle. With chronic tears, pain become instability and weakness in the ankle. This feels like your ankle would give out as you walk, especially on bumpy surface. So this is a symptom of peroneal tear. And what causes the tear? Sudden trauma to your ankle, such as inversion angle sprain, that is rolling your ankle inward, or chronic stress and pressure on your tendon from overuse. This is from the literature research, I found this is explanation of the peroneal tear. I think this is how it is tear occurring and all. That is from the literature, exactly like our picture, the torn peroneus brevis and the normally peroneus longus. So what will you do? See, the tendon is also ruptured, you will not have any movement. Nerve is there, muscle is there, but the tendon rupture means you cannot have that movement of the ankle.
Sir,
So
when the nerve is involved, when the nerve, due to any cause, a nerve is involved, there will be the involved muscle usually has a T2 flare hyperintensity, sir.
yeah.
So when there is long-standing muscle atrophy, the tendon might go for rupture, sir. So why this might be a cause of some other thing, sir?
Then also you have to explain why the muscle is affected or see, is the loss of his inversion due to the tendon rupture in this way? That's the question to decide. See, he's not everting the angle. That may be due to the muscle paralysis, that may be due to the tendon rupture. Ultimately, the muscle has to act through the tendon only.
Yes, sir. So
Yeah.
the opposite superficial peroneal, sorry, the peroneus longus also has fibrillation, sir. So
That's on the other side. No, that is totally different. See, that fibrillation on the right side is there, but other potentials are all normal interference and no weakness. So that fibrillation may be part of his older diabetes mellitus producing a peripheral neuropathy part of it. Okay, but the present problem is what is causing is left inversion of the foot. That is what's come to you. With that, we have to find an explanation.
Sir, EMG of all other muscles were normal in this patient, the potential?
No, I did not do because see, I was concentrating only the supraperoneal muscles. I mean, peroneal longus and brevis muscles. Because I didn't want to do it. So if you find fibrillation maybe in the hand also, distal muscle also, you may find fibrillations. Being a diabetic, that does not mean, that will not explain our patient's present problem. See,
Recurrent ankle inversion.
he has got a syrup or the peroneus. You cannot keep it even if the against gravity, you cannot keep it. It goes inside. How can a peripheral cause that thing?
Traumatic injury, sir.
Yeah, that's a possible. Traumatic injury to the tendon is possible. So that is what the radiologist suggests. That the literature also says that sometimes you can have sudden trauma to the ankle, such as inversion angle sprain, can rupture the tendon. And overuse also can produce rupture the tendon. So,
Sir, how the tear occurred? Did he fall, sir?
no, he does not remember the fall, but what they say is that sudden inversion injury by some means from getting out of the. He first noticed that when he was climbing down from bike or something, suddenly the foot got inverted, and that time since that time noticed the weakness. It may not be trauma. Maybe notice for the first time the weaknesses produce the inversion fall. That's also possible. Or maybe trauma just got a tendon rupture also is possible. Radiologist suggested tendon repair so that he can, because that also can produce inversion weakness. So what do you think? Will you send for surgery or not? Why not?
Sir, we can do surgery, no? The tendon repair.
Yeah, you can do the tendon repair. So I said for an ortho consultation, but I was not happy in my mind for one reason. I tell you later on.
So the nerve supplying the muscle also is important if it is intact.
Yeah, that's correct.
Because if it is injured, if the nerve is also injured, it will be weak and will be recurrent inversion injuries because there is no power in the peroneus to hold.
That's agreed. No, that's agreed. But the problem now is there a nerve lesion causing the weakness and inversion? We did not find any nerve lesion in the MRI, and it's not the common set pressure palsy. And what we find that there is a tendon tear. That means even if the muscle is the muscle cannot act, no, the tendon is ruptured. That may be responsible for the inversion of the foot while walking, because inversion is not acting. Inverters are not acting. It is act through pulling on the bone, no?
So even if you repair the tendon, the nerve is, we don't know the status of the nerve, sir. So
correct. There may be associated involvement. Yeah, correct. What you said is correct. We don't know the nerve the status, agreed. But so far the imaging is normal. When it's stimulated.
But the MRI after the MRI is not showing any nerve pathology, nor does the nerve conduction studies. So we can presume that the tendon rupture might be the cause.
Right, correct. That's correct. Okay.
So, but when you stimulated, when you did the co-stimulation of common peroneal, the peroneal nerve didn't conduct the impulse, sir. That means that there might be a nerve involvement, sir. So I couldn't agree alone that only the tendon.
So nerve involvement will cause muscle weakness, and that's how there is inversion because everters are not acting.
No.
And
I'll tell you what she says is correct. I'll come. That is a secret I was keeping it behind. So radial says tendon repair. Then I said, what did I do? I was not convinced about that. In the ortho consultation, he opined that here tear of the only peroneus longest tendon. This cannot explain the weakness. The longest tendon is okay. Now I have to prove that it is not due to the tendon rupture, it's got a weakness, inversion failure, but due to the nerve involvement. Then what will you do?
Repeat. Now conduction study.
EMG. Like conduction from where? Because the EDB conduction was already done. That's showing a normal.
Between the two heads of the fibula, we have to stimulate below and above the knees to see whether there is.
That's okay. Wherever it is stimulate, so both supraperoneal and deep peroneal will be stimulated.
EMG in the peroneus longus.
EMG for denervation.
EMG did not show any denervation. It's only no potential has been picked up.
Distal in the nerve.
Yeah, no, you cannot stimulate supraperoneal nerve alone. It is inside the muscle. You can stimulate only the conperoneal nerve around the fibula. I put the needle in the muscle. There's no potential coming from there. Nor I could not get any on activating. There's no activation at all.
Sometimes, sir, diabetes also causes muscle infarction.
Yeah, but there's no infarction here in this muscle. Only diffuse hypertension.
Peroneus longus EMG.
That's what it initially did. On the right side, it is normal. Here, no potential is coming out.
So it doesn't work.
No, I'll tell you the simple thing. The answer is there already in the pre-question itself. So what I did, I simulated the conperoneal in a fibula head. and pick up electrode on the peroneus longus on the right and left side. Because if only tendon tear is there, the muscle should still contract, no? If nerve is intact. So what he did, put a proper surface electrode. This is on the right side, stimulate on the right PCP and CPN, and pick up electrode on the right peroneal muscle. See, I put the electrode on the peroneus longus and stimulating from the converoneal nerve. You now see the muscle has got a good potentials coming up. That is on the right side. Now what I did from the left side now. This is supraperoneal muscle. Then I stimulate the left side. No potential is coming on the left side. Go on increasing. Increase up to the 60, 65 milliamperes increased. Still no potential. There's no potential. No potential in the peroneal on stimulating this thing. Superior conperoneal. That means this is not due to the tendon rupture at all. If tendon rupture is, the muscle should still contract on stimulation. So the tendon rupture is not causing his eversion weakness. That means it is not femoral tendon rupture. There is a conduction block at the supraperoneal nerve predominantly affecting the motor part. Why not axonopathy? Because there is no denervation even after 3 months. So some conduction block must have happened in the proximal part of the supraperoneal nerve, causing this weakness. So what will you do? So put him on a course of steroid, even though he's diabetic, and ask him to come back follow up. Okay. Now this is the puzzle. That is why I brought this case. Okay, you must have a lot of questions. You can ask me the question, I'll answer it.
Did he improve, sir, with steroid?
No, this last week's case. I'll tell you, let me show the follow-up later. Yeah, please. Because there is no other possible. He has got a site of lesion in the supraperoneal nerve, and there is no structural such in the sense that tumor or a trauma in the nerve. It's not a site for pressure palsy. The only thing is that some kind of a demyelinating condition, a mononeuritis, the diabetes. And that is not an axonopathy, remember that. Yes, no speculations coming from the supraperoneal, even after 3 months. That means not axonation affected. And there is no wasting of the supraperoneal muscle also. The muscle is not wasted. I'll show the muscle. It's not wasted. That's right side. This is left side, and the previous one also.
So that muscle is a little hyper intense, no, sir?
Yeah,
which
that can
indicates like maybe diabetic muscle infarct.
No. It's not infarct. See, any nerve lesion can even tendon rupture also can produce hyperintensity. The muscle is not contractile, it will produce hyperintensity. Any nerve lesion can produce hyperintensity. So that's not a very non-specific thing, hyperintensity in the muscle. Even if you do not use the muscle also, it will produce hyperintense. See the muscle bulk is not there, not atrophy in the muscle bulk at all.
They say that if you take stir images of the muscle, you can differentiate between edema and fibrosis.
Which one?
If you take stir images also, that STIR sequence.
No. What will produce hyperintensity? Whether it is an edema or due to denervation, cannot produce hyperintensity.
So what is the cause of muscle hyperintensity in this patient?
I do not know how to explain that thing, but very often we find that, initially we used to think that's due to the muscle edema or muscle, any neuropathy can produce that thing. In brachial plexopathy, muscle hyperintensity is well known.
But it's 3 months old now, sir. It should have subsided now. It's 3 months. It is the hyperintensity is still persisting.
It will persist because the muscle is not acting.
We have to go to atrophy, no, sir, but there's no atrophy of the muscle in the MRI, no, sir.
That's the point. That's it. That's what they said. To atrophy to occur, the muscle should have an axonopathy. If it's a demyelinating block, you will not have an atrophy. Those axons are intact.
Can we call myositis, sir? Focal myositis?
Yeah, but how can you explain a myositis with only, if it is a myositis also, you explain with the total loss of muscle strength of those two muscles alone, and the nerve stimulation does not produce any potential.
Maybe mixed myositis with focal conduction neuropathy also.
That we can say that way, but same thing can be explained with supraparietal neuropathy, then why do you want to bring in myopathy? That's the question.
Because the MRI is showing muscle changes. That's why, because
that can occur. No, that can very well occur with any, even DML neuropathy also muscles conductivity will occur. This time and again, I've gone, initially I used to think like that.
Sir, upper limb examination is completely normal, sir.
Normal. Upper limb is completely normal.
Even sensory.
Even sensory, everything normal. There's no complaint in the upper limb also at all.
Sir, one question, sir. In patients of such kind of diabetic neuropathy, how do we exclude UMN causes of nerve involvement? That is foot drop, that is a cortical or a cord. If frank cord features are not present, or a UMN like a anterior hornsill disease can present only with one group of muscle weakness. Because of the sensory overlay, we may not get the diagnosis. So,
okay, tell you. When you want to look, suppose you got an element paralysis. When you suspect he has got an anterior hornsill disease, that the involvement of the muscles should not fit in with the nerve distribution, should not fit in with the root distribution. It should be a patchy involvement. If muscles are respecting, suppose you have got let's for example, you have got weakness of all interosseous muscles are weak, only interosseous. Hypothenar is expired, sensory is not there. You may think it's motor neuron disease. Okay. But before thinking motor neuron disease, think, can it go with the nerve pattern? Yes. Because a deep branch involvement of the ulnar can produce only interosseous weakness and adductor pollicis weakness. So in motor neuron, if you any disease which respects a nerve pattern, do not consider anterior hornsill disease prime. It may be, but don't think initially. Because you are missing a nerve lesion or a root lesion. So it's the first dictum. So anterior hornsill disease produces a patchy involvement. It picks up one muscle from one nerve, another muscle from another nerve, or one muscle on root, other on the root. That is the pattern it takes for anterior hornsill disease.
yes.
Focus
Here, pardon? And moreover, always in neurology, the logical thing is very important. See, he has got zero for the superior peroneus centralis, but no weakness of the other muscles. Is it common with a combination? Is it likely with a motor neuron disease? Very unlikely.
The cortical involvement can.
Yes, cortical involvement, yes. What you said is correct. Cortical lesion can produce a cortical foot drop can occur. Agreed. That without sensory, that possibility is very strong. In this case, yes, sensory is not conforming to supraperoneal. Agreed. So that should make it negate cortical foot drop also. But usually in cortical foot drop, the other dorsals also should be affected. They're only confined to the invertebrates is also very odd.
So can it be a Madsen variant of CADP?
Yeah, it may be, but only thing is the one nerve is a node is affected. Then we can't call it as a CADP. You can say focal CADP, yes. Very focal CADP. Then better you can call it plexopathy. You can invite one nerve is better to say mononeuropathy. And one nerve is affected is a mononeuropathy. It can be demyelinating neuropathy or axonal neuropathy.
So the cutaneous branches of superficial peroneal nerve, they arises after the muscular branches or before the muscular branches, sir?
Before the muscular branches. It is a superficial branch. If it's affected deep, it can be spared. And moreover, in some case, demyelinating mononeuropathy, sensory may be totally spared. For example, in the case of, say, I've shown you 2-3 cases of neurologic hemiatrophy, where the only the radial nerve, the what do you call the posterior introsterior nerve one part alone is affected without sparing, totally sparing sensation. Median nerve brachial neuritis can produce only flexor polys as long as muscle weakness. That also is shown 2-3 cases. All of the muscles separated with the anti-intrusion nerve is spared. Only flexor polys. I think I'll show that case next week.
Sir, so can we call it neurologic hematrophy of the lower limb, sir?
Yeah, it is very good. That's a good possibility. It can be neurologic hematophy of the lower limb. Why not? That's a possibility. It's all only in terminologies. Actually, what's the nerve? What you have to know is that where is the lesion? Okay, lesion is in the supraperoneal nerve. It is a tendon, it's not in the tendon structure. Because even though there is a tendon demonstrated by the radiologist, that's not causing it. So then what could be the etiology? That is then the pathology of the nerve is demyelinating, not axonal. Why not axonal? Because there is no spontaneous activity and no wasting of the muscles, even after 3 months. So that means it's for demyelinating lesion. Then there's a good chance of improvement with steroids. So they started steroid.
Will ultrasound of the nerve help? Supraperoneal nerve.
Ultrasound of the supraperoneal nerve, I do not know whether ultrasound will going to help in this patient. Because ultrasound is going to pick up, it is a deep branch, it is going inside. So ultrasound will not pick up. See, I'll show the position of the supraperoneal. See, that is the deeper and that is supraperoneal. Ultrasound is very unlikely to pick up nerve unless it is superficial. Deeply located cannot. Shall I go to the next case? Any questions, please? Then we'll go to this case.
Next case.
Yeah. No, the idea of bringing the case is that you have to pursue to find out the cause one after another. This also I was totally confused initially. So initially I believed the radiologist could be 10 reps. Then I started thinking, then why there's no potential coming from that this thing on stimulate? Then started doing it again. I found that no potential is coming out. So it's only simple logic today that it's not a tendon rupture. Okay, I think I'll skip this long case. I will go to the short case. That's better because that takes a long time. I'll go to the short case then. This is also something interesting, peripheral problem. It's a 50-year-old man presented with history of numbness of left palm as well as inability to use his left hand following a fall 4 months back. Remained static since then. So numbness of left palm, inability to use his left hand. So this examination finding is deltoid was normal power, triceps normal, wrist extension is normal, finger extension is normal. Intrusion is mildly weak, not very significantly weak. It's weak, of course it's weak. Abducted digit minimi is weak. This is also weak. The finger flex on the right side is normal. But on the left side, zero power. Finger, not at all flexing at all. So, see, all the finger flexes were weak. Flexor polys long is also weak. Flexor polys breve is also weak. Abductor polys long is also weak. You cannot keep it abducted. All intrusive were weak. But not as weak as the finger flexes. See, you cannot adduct the thumb at all on the left side. Come with the reflexes. Normal biceps, normal supinator, normal triceps. Is it same? Same. Mild decrease on that side, but that is decreased. Then you will point out where the sensory loss is. That is increased. Is a decrease on the middle finger.
വ്യത്യാസം. ഇത് നോർമൽ ആവുമ്പോൾ പറയണം. നോർമൽ ആയാൽ 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 പറയണം. നോർമൽ ആയാൽ
Then is normal. Not able to feel vibration properly. So I'll tell the findings once again. Weakness almost zero for the finger flexes, flexor pollicis longus, and abductor pollicis longus. Moderate weakness of thenar muscles, hypothenar muscles, and all intrusion. Moderate significant weakness. Normal power of the extension of the wrist, extension of the fingers, and extension of pollicis longus. Sensory impairment in medial to fingers up to the mid forearm on the medial side. So this is the finding. You want to see the findings once again? I can show. You want to see the video once again? The weakness?
Yes, sir.
Okay, I'll show you once again. That's very interesting finding. The initial part I will skip. This one I will skip. That is normal. That's also weak. Dorsivay weak. That is normal on the right side. Abducted digital minimi weak. The first FTI weak. Finger flex on the right side is normal. He cannot flex at all. I was surprised to find zero power. Previous policies, the internal longus and sublimis were normal. Flexor pollicis longus is weak. Flexor pollicis brevis is weak. He cannot keep the thumb abducted. Keeping abducted, it falls down. Then the palmar indosea were all weak. Adduction is not at all possible in him. Of course, that's the finding. The reflex is normal, but sensory loss as already shown before. Medial to fingers up to the mid forearm, somewhere here.
Sir, involvement of multiple nerve regions, lower brachial plexopathy in background of trauma can be a possibility.
Perfectly right. So where exactly is the lesion? That's the question.
C8D1.
Okay, very good. C8D1 can explain perfectly well because that's a supply of the C8D1. Because C7 also, even
Restriction also affected, sir.
Long is also affected, sir.
Yeah, that can be affected in the C8 also. The C8 is supplying the long finger flexors also. C8D1 is one possibility. Where else is possible?
Lower trunk, sir.
Correct. Because you cannot differentiate C8D1 from lower trunk. Because C8D1 forms a lower trunk. So exactly the same thing. No nerve is coming out from the root of from the C7 C8D1 root, other than the hornous sympathetic fibers. So the pattern of weakness is exactly same for lower trunk as well as C8D1 root. So that's another possibility. Where else is possible? Can be medial cord.
Abductor pollicis longus is affected, no, sir?
Yeah, that can be affected in medial cord also.
Yes,
So
sir. Can be
ultimately, the medial cord I think is a continuation of the lower trunk.
So wrist extension is paired, sir. So
Recession is normal.
so medial cord.
No, but the recession is mainly supplied by the extensor carpi radialis longus, extensor digitorum. They're all supplied mainly by the C7, middle trunk, to the radial.
So with this lower trunk, there should be involvement in the median also.
Medial, of course, medial. But the question is, why can't be if lower trunk agreed? Why not be medial cord?
Middle cord is possible. Middle
cord is also possible. That middle cord is a condition of the lower trunk.
Yes.
Medial cord should cause the sensory loss in the lateral aspect of the forearm, sir. I mean, like, can we argue like that?
No. Lateral aspect of the forearm is musculocutaneous nerve produced, separated by the lateral cord.
Yes, sir. Yes, sir. Yes, sir.
It should produce sensory the middle forearm agreed. That is affected here partly.
Pectoralis major is bad.
Pardon?
Pec major, sir.
Pectoralis major, the problem is it has got multiple root supply. It is supply the lateral pectoral and medial pectoral. And if you it supply from C5 to D1, it's a supply, C1 to C8. So that is not going to get much because other nerves are supplying it. So you may not get a weakness with the pectoralis muscle.
Here it is more probable. But medial cord is the most probable.
Yeah, most probably. Okay, this is the possibility. Agreed. Now, what you all said is correct. CAD with radiculopathy.
Sir?
Yeah.
Sir, abdominal polysis longus nerve supplies from posterior introitious nerve, sir.
Correct.
But that is under the from the posterior cord, no, sir, that comes. So we can't call medial cord.
No, abductor polysis longus is separated by the radial nerve. What you said is correct. But that is that posterior medial cord is unlikely to do that. That is correct.
So then we have to include the trunk only, trunk and above.
Yeah, yeah. So there's maybe lower trunk is possible.
Yes, a lower trunk and the CAT1 route.
Yes, possible.
Yes.
The NCS followed by imaging to route also.
There is these possibility. Now, why can be median ulnar nerve then? More two nerves are affected.
And then again, abductor polysis.
For the middle half of the sensei, forearm is affected.
Yeah, that's a point again. It's perfectly right. That the middle, because they're affecting onto the medial forearm. So that's very unlikely. So what investigation do we need now?
NCS.
NCS. So NCS is a median. These are on the right side. Ignore that thing. On the left side, left median is inelicitable motor conduction. Left ulnar is inelicitable. That means both hypothenar and thenar muscle is affected. Radial is normal. Okay. Then musculocutaneous is normal. Axillary is normal. Now coming to the sensory, median sensory is normal. Ulnar sensory is inelicitable. So what does it tell you? What does it exclude?
So radiculo.
Yeah, so radiculopathy is excluded because radiculopathy expect a sensory potential to be preserved.
Normal.
It also excludes one more thing, it's unlikely to be median ulnar nerve involvement because medial sensory is spared. So that's just likely to be that combination. Already we have got some other point also against a medial ulnar nerve. So that means radial nerve amplitude is also normal. Okay. Medial anti-brachial unit is also normal. That's also against a medial cord involvement or a CAD radiculopathy or a lower trunk involvement. But that need not always, all nerves need not necessarily be involved. Right upper limb is normal. This is a CMAP from the left ulnar, left median. Radial is good potential. So the abductor polysis longest weakness maybe need not necessarily be due to the posterior cord involved. Maybe some supply may be there from the ulnar part also may be contributing to that. Because other things, radial, other muscle radial is preserved. That's what it is. But as you said correctly, that is conventionally supplied to the abductor polysis longest is by the this thing. Left median snap, radial snap is normal. Now, what is the localization now? So what we can exclude is CAD1 is excluded, medial ulnar nerve is excluded. Now two things remain, lower trunk and medial cord, electrophysiology.
Sir, extensor indicis proprius, which comes from lower trunk, goes to the posterior cord.
Perfect. That's the answer. So if you can demonstrate that extensor indicis is preserved, that means the lesion has to be in the medial cord. If it is lower trunk, it will be affected because that indicis muscle go through the posterior cord. Okay, right. That's the way to differentiate the two. So what do you want to do now? Differentiate the two.
Can you please explain again, sir?
I'll tell you. The lower trunk, the upper, middle, and lower trunk. The lower trunk divides into a posterior division and an anterior division. The anterior division continues as the medial cord. So the posterior division of the lower trunk joins with the other things and forms the posterior cord. So only very few muscles are supplied by the lower trunk through the posterior division to the posterior cord. One is extensor indicis, the other is extensor carpi, some other extensor, one more muscle is there, classically it's indicis. So if that muscle is affected or spared, that means the lesion is not in the medial cord. Because those fibers supplying the extensor indicis go through the posterior division of the lower trunk and joins with the posterior cord. Whereas the anterior division or ventral division continues as the medial cord. So the supply, if the medial cord lesion is there, if lesion in the medial cord is there, the supply to the extensor end is already gone, escaped. So that will be preserved. Is it clear now?
Yes, sir. Thank you, sir.
Yeah, right. Now, so what will you do? Want to know EMG of which muscle? EIP bus done. So EMG was done from the extensor indices. That is a very easy muscle to do the EMG, and that is where we put the potential also. The clue is also there in this patient. Electrophysiologically, that potential is normal. But to be certain, we can do the EMG once again. But sound is not coming. There's got a good potential coming from the the sound is not coming. Anyway, you can make out the potential here from the EIP. And this EAP, no potential. Let's say this is the EAP. There is a first dose introduction supplied by the ulnar. Abductor pollicis brevis supplied by the median affected, but EAP is preserved. So there is lesion is in the left medial cord affection. This is the thing which I already said. According lower tongue lesions involve all ulnar muscles in addition to the medial CA-D1 innervated muscles, abductor pollicis brevis, flexor pollicis longus, and flexor digitorum profundus. Radial CA innervated muscles like extensor indicis proprius and extensor pollicis brevis. Sensory loss involves the medial arm, forearm, medial hand, and fourth finger. So the same thing which I told. So medial cord is a direct continuous anterior division of the lower trunk. These medial cord lesions are nearly identical to the lower trunk plexopathies except for the fact that intact radial C8 fibers, C8 fibers going through the radial nerve, which pass through the posterior division of the lower trunk and then through the posterior cord. So medial cord lesions result in weakness of all ulnar muscles and CA-D1 median muscles, APB, pollicis profundus. Notably, finger extensions will be spared. I think this you can skip. Now, on retaking the history, what happened means a piece of asbestos sheet penetrated his left axilla. A plastic surgeon operated on the axilla and the wound was sutured. And weakness of retin is persisting even though he noticed mild improvement in his numbness. So that's the story.
Sir, clinically, there was any weakness in the extensor indicis proprius?
That alone is very difficult to test. In fact, I did not check that thing because there is also other extensors for the index finger. Extensor digitorum is also supplying the extensor indices. So
Sir, is there any way to specifically examine for the EIP clinically?
Yeah, no, what we usually do when you do the EMG, you put a finger for the four fingers above the ulnar, the ulnar end of the ulnar, and then ask the patient to extend the index finger. You can feel the extensor indices contracting. Unlike the other, that's a distalmost muscle in the extensor compartment. So you can easily palpate this muscle. Selective examination will be little difficult because extensor digitorum is also supplying the index finger.
Yes.
Okay, shall we close it?
Thank you,
Sir,
sir.
in second case, how did you come to conclusion that it is the narrow involvement, sir?
No, only by exclusion of other things. Because on stimulating the conperonal, nerve potentially spectra from the supraperoneal peroneal. That is the reason.
NCS, sir?
NCS. Usually, conventionally, in the NCS, where do you pick up? You pick up the EDB, not from the supraperoneal peroneal muscle. Here, I put the electrode on the supraperoneal peroneal nerve and stimulate the conperonal nerve.
Okay.
No potential on the supraperoneal peroneal muscle. Because EDB is separated by the deep peroneal. That is why potential from the EDB is not.
Okay, sir. Thank you, sir.
So shall we close it? See you next week.
Yes. Thank you, sir. Good night, sir.
Thank you, sir. Good night.
Thank you, sir.
Thank you, sir. Good night.
Thank you, sir.
Good night.
Yes, sir. Thank you, sir. Good night.
Good night. Good night. Good night.